Hello, I'm glad that you joined me today for this quick session on perinatal periods of risk. This is to help people who don't know a lot about it have some context for the two other sessions in this symposium about data quality and the national analysis. So this will give you the background you need, although it will be fairly quick. I'm Carol Gilbert. I am at CityMatch, which is housed at the University of Nebraska Medical Center, and I'm happy to be here. The perinatal periods of risk approach is a large approach to cover all kinds of community activity as well as analysis. And what I'm going to be talking about today mostly is the analysis. PPOR provides a framework and steps to investigate infant mortality at the local level, starting with at least vital records data. It does include standard EPI tools, and it creates new ones, but it is designed to be used as a part of a larger urban community planning process. Otherwise, it will just be another report that sits on a shelf. So there are 6 stages of the perinatal periods of risk approach, and the analysis lies within these. The first is to assure readiness, and that takes some work to get the data, get somebody to analyze it, get their time allocated, and to get a community group ready if it's not already. And if there is a community group, to work with them about the data to make sure that they're really on board and understanding what's going on and can contribute to this analysis. So the second stage is to conduct the analysis. And that actually can go on for a long time, a short time, and then it can continue. Then develop a plan based on the findings, strengthen existing things, or launch new prevention initiatives, whichever the plan is, monitor and evaluate what happens, and sustain investment by telling people about the successes. So why do we do PPOR? Why do we need it? The main reason is that just the infant mortality rate doesn't tell us what to do. And so many communities know about their high infant mortality rates or their disparities, and they really want to know what to do about them. And this is what PPOR helps with. If you want to do PPOR, you have to get access to the raw vital records data files. That is a row for each person, so case-wise data, and you need somebody who can analyze that. It's not rocket science, but it takes a little bit of software to help you. And every population that you want to study has to have at least 60 deaths. So if you're in a very small community, you may not have that many deaths, and that's okay. You can still look at some quantitative data, but it won't be exactly PPOR. And you can combine years up to 5 years, we recommend. You also need that team of community collaborators and champions to make this data used. So the 3 vital records data files you need are the live birth certificate files, that's the biggest, of course, fetal death certificate files, infant death certificate files, which are linked to the birth certificate information. And every state produces these and gives them to the federal government, but also still has access to them and should give them to public health officials who are working to improve health. Advantages of PPOR include that it makes full use of all the available data and other information that already exists. It identifies gaps, and especially it estimates preventable mortality. It's hard to do that at the population level. It helps communities target resources because they'll have information that tells them how to target them. It helps communities make the case to funders and policymakers. So they may know what's wrong, but they have to prove it to funders and policymakers with data, and this allows them to do that. And it also can help mobilize the community to action because often they don't realize that there is room for improvement. We do get stuck sometimes in the feeling that things have always been this way and they always must be this way. And that's one of the things that we're designed to change with PPOR. So another important thing about PPOR is that it includes fetal deaths, and they are an important part of the picture. There are more fetal deaths than there are infant deaths. Fetal deaths are important to their families, of course, but they're also just as much as infant deaths can be. They are indicators of health of a community as well. They are, not all of them are just have to happen. Some are preventable. So phase 1 analysis in PPOR begins by sorting the fetal and infant deaths into 4 periods of risk that are defined by 2 characteristics. First is age at death, from fetal deaths to neonatal in the first month, to post-neonatal from the second month to the year birthday. And birth weight, which goes into 2 categories. Less than 1,500 grams is very low birth weight, and bigger than that. The less than 1,500 grams are all in one period, no matter what age they died. That's the blue box, maternal health and prematurity. The larger babies, maternal care period is the fetal deaths, and the newborn care period is neonatal, and the infant health period is post-neonatal. You might notice here that fetal deaths that are less than 24 weeks are not included here. They have to be, that should be greater than or equal to. And also infant deaths and fetal deaths that are less than 500 grams are not included. And that is the topic of the data quality presentation, which you may be viewing next. PPOR directs action because each period was designed, the periods were defined based on having similar maternal risk factors and infant causes of death. So each period has those things in common, and that means they also have directions for solutions in common. It's not perfect, there is some overlap, but these periods do narrow down the focus of what you need to work on. In step 1, we sort the infant and fetal deaths into periods of risk. And here's an example for a southern US county. There were 114 fetal and infant deaths in the maternal health and prematurity period. There were 72 fetal deaths in the maternal care period, and so on. The next part would be to divide each count by the total live births and fetal deaths. Each count gets divided by the same number, and that gives you a rate. You multiply by 1,000, just like for infant mortality. And that gives you a rate that sums up to the overall rate. So it's not rocket science so far. But an important question to ask now is how many deaths or what rate should we expect to see in each period of risk? You notice that the rates were higher, the rates and numbers were higher for the blue box, but those are very low birth weight births, right? You wouldn't think that they would have more deaths. We really need to have a benchmark, and PPOR uses reference groups to estimate preventable fetal infant mortality rates. The reference group is a real population of babies that are defined by their maternal demographics and agreed upon by the community to be a standard. It provides a baseline for the community. It's a mortality rate that has already been achieved. If a death rate exceeds the baseline rate, we know there are conditions. There is a way that some of these deaths could have been prevented because one group has already done that. PPOR phase 1 tells the team which periods of risk and populations have the preventable deaths. That is, where are the gaps? There are some guidelines for the reference group. It has to be a fairly large group. An important one here is that it has to be acceptable to the community. And these are the traditional criteria. 20 or more years of age means we don't have teenagers, a little bit higher risk for different reasons. And 13 or more years of education is used because it's a proxy for socioeconomic status for the mother and for her parents too, which really does affect her health. And race is a powerful social construct in the US, reflecting generations of unjust systems, but it still is a marker for health. The reference group is chosen oftentimes to help the community make a case, a particular case that they're trying to make, that they should be able to reach this goal. So the third step is to make this reference group, and here is one of the new national reference groups. This is the white, non-Hispanic, the traditional reference group. So this is the group we're going to use to compare this one county to. And we're going to do that by subtracting. In the maternal health and prematurity period, the rate was 2.95. We subtract the reference group rate, which is 1.53, and get an excess rate of 1.43. That's 1.43 excess deaths or preventable deaths for every 1,000 live births and fetal deaths. The same method for all of these, and these excess rates adds up to the overall excess rate. And you can make a pie chart to summarize. The mortality rates are here, and then the excess mortality rates are in the next chart on the bottom. The excess tells you how much of that is preventable, and it's interesting that the excess increases for the blue part of the pie, and it decreases for the yellow part of the pie. And that means that fewer of those yellow ones were preventable, but more of the blue ones were preventable. So fewer newborn care and more maternal health and prematurity. So there is another phase of PPOR that I won't go into detail on here, but it begins by investigating the two bigger parts of the triangle, and they're not always the same ones, but I'm going to show you how to divide the maternal health and prematurity period into two pieces, and that's using the Kitagawa method to figure out whether this excess mortality is due to birth weight distribution, that is too many babies born too small, or birth weight specific mortality, which means survival is not what it should be in the study group. And then for the green box, one of the major causes in the green box is often sudden unexplained infant death, which is 3 ICD codes that are related to sleep, infant sleep. So the green box is divided into two parts based on cause of death. The blue box is divided into two parts using Kitagawa analysis, and the other two boxes are left as they are because it's not very easy to figure out mechanisms, causes of death for those. So phase 2 focuses on the population and period of risk with the largest gaps, and it really asks these two questions. What are the likely causes of this gap? And then what interventions are most likely to work? Those really are two different questions. And what we can do to figure out the answers is all 4 of these things. We can do further epi study, which is phase 2 PPOR analysis, but we also need to check the scientific evidence, make sure we understand the community health systems, and have the right experts at the table that know those things, and not just health systems, but all the systems that affect health. And we really like to have fetal infant mortality review data because that brings in really good details about what happened to each death, or some deaths anyway. And most importantly, it brings in maternal interviews, which are not, the mother's point of view is not really represented in any of these other data sources. So part of a typical phase 2 analysis might be this, just comparing the prevalence of risk factors between the state reference group and the population that you're studying. You can see ones that have bigger differences might be the ones that you are worried about the most. You can also consider the riskiness of the risk factors. And we do that with the risk ratio, that middle column. It's just the risk of those that had the factor divided by the risk of those who didn't. And the bigger the number means that the factor is stronger, more risky. And if a factor is both prevalent and risky, it will come out to have a high population attributable risk %. And that's just a good way to sort of sort factors and prioritize. It's not the only way, but it's a good easy way. So here we might prioritize these red ones first. Think about those first. And maybe we report to the community something like this for the end of PPOR. Well, although it never ends, but This too many very low birth weight births contributes 75% of preventable blue box deaths and 31% of all excess mortality. The important causes that are likely to be important, either causes or markers, are being unmarried and having a high school or less education. Those are both social factors. Having late prenatal care or having a previous preterm birth are related to the health systems. And most importantly, or maybe at least equally importantly, there's a bunch of factors that really aren't contributing to this particular gap. So if we want to work on the gap that we identified with our reference population, we want to work on the left-hand column. And the other ones might be important for something else, but they won't help us with this particular thing, or at least not likely. So phase 2 fosters integration with other efforts, and you can bring in information from all of these sources. You should, if you can. And for further details, we have some training and technical assistance available at CityMatch, and we're happy to help you learn this better. Thank you very much for your time, and feel free to email me if you have questions, comments, suggestions, complaints, any of those things. Go on and see the other 2 presentations.